Hello, I'm Dr. Sai Praveen, neurologist at Akkineni Hospitals. Hope you are doing well. In this session, we'll discuss some crucial points. Stay attentive and make your notes.
Welcome to The Explainer. Today, we're diving into something that is so drastically misunderstood. We're moving way beyond this idea of just a bad headache. No, we're going to break down the complex biological reality of migraines. We'll look at the clinical mechanisms driving the pain and the therapeutic management strategies we actually use to fight it. And well, I want to start right here with this absolutely massive global statistic. 1 in 7. 1 in 7 people worldwide suffer from this condition. That is a staggering portion of the human population, right? If you aren't dealing with this yourself, you almost certainly know someone, work with someone, or love someone who is. And we really need to validate exactly what those people are going through. Migraines are the second leading cause of disability worldwide. Think about that for a second. According to the Global Burden of Disease study, for people under 50, migraines literally cause more years lived with disability than diabetes, epilepsy, or even asthma. It is a profoundly debilitating neurological disorder. So here's our roadmap for this explainer. First, more than a headache. Then, the biology of an attack, followed by identifying your triggers. After that, we'll cover the acute treatment arsenal, and finally, preventive and chronic care.
Okay, let's dive into section 1, more than a headache.
Because the demographic impact here is just enormous. Just in India alone, there are roughly 150 million sufferers. But what's really striking, and you might have noticed this in your own life, is the stark 3-to-1 ratio of women to men affected. And despite this massive prevalence, the reality, which is honestly a tragedy, is that migraines remain dramatically underdiagnosed and dramatically undertreated across the board.
So, let's move to section 2, the biology of an attack.
It's time to completely shatter the myth that a migraine is just a regular headache, because the neurology here is fascinating. To understand what a migraine actually is, we have to look at cortical spreading depression. I want you to imagine this as a rolling blackout moving across the surface of the brain. It's literally a wave of electrical depolarization followed by total suppression just sweeping across the cortex. And this wave, that's the biological mechanism that generates the aura so many patients experience before the pain even hits. And then we have central sensitization. During an attack, the brain basically becomes an amplified stereo system. Everything is just turned up to an agonizing volume. This, combined with the activation of the trigeminal vascular system, which is the main pain generator here, explains this wild phenomenon called allodynia. Allodynia is a state where even a normally harmless, light touch to the skin becomes physically painful. Your brain is essentially misinterpreting totally normal signals as severe pain. Let's contrast the two main types of migraine. The vast majority, about 75%, actually happen without an aura. The headache phase just kind of begins. But for the other 25%, the attack is preceded by 20 to 60 minutes of fully reversible neurological symptoms. We're talking visual stuff like flashing lights or blind spots, sensory stuff like a tingling spreading up your arm, or even speech disturbances. The absolutely crucial point here is that experiencing an aura actually increases a person's stroke risk. In fact, because of this risk, combined oral contraceptives are contraindicated, meaning they definitely shouldn't be used for women who experience migraine with aura and who also smoke.
Now that we understand the biology, let's transition to section 3, identifying your triggers.
These are the environmental and physical factors that actually provoke those biological attacks in the first place. And look, triggers are highly individualized. What sets off an attack for one person might literally do nothing to another. It could be anything from sleeping too much or too little, skipping meals, dehydration, or, of course, stress. Even the letdown period after a really stressful week can trigger a weekend migraine, as if Monday to Friday wasn't hard enough. Alcohol, particularly the tragedy of red wine and beer, is a major culprit, alongside hormonal changes like menstruation, bright lights, strong smells, and even weather-related barometric pressure changes. The absolute most powerful thing you can do here? Keep a dedicated headache diary. By systematically tracking and then avoiding your specific personal triggers, you can significantly reduce how often these attacks happen. But what happens when avoidance just isn't enough? Let's look at section 4, the acute treatment arsenal. This is all about aborting the pain once an attack actually begins. So let's look at how medical professionals escalate this treatment. We start with NSAIDs, like ibuprofen or naproxen, as the first-line defense for mild to moderate attacks. If those fail, or for really severe attacks, we move up to triptans, like sumatriptan. These work by actually constricting cranial blood vessels, and they need to be taken early, ideally within 30 to 60 minutes of the attack starting. Now, for patients with cardiovascular risks who can't safely take vasoconstrictors, we pivot to Jopants. These are newer oral alternatives that block CGRP without constricting blood vessels. And finally, antiemetics can be added to the mix. These don't just reduce nausea, they actually help your stomach absorb the pain medication better. Pretty clever, right?
But here is where things get really tricky. If you use triptans for more than 10 days a month or NSAIDs for more than 15 days a month, you can actually trigger a paradoxical worsening of your condition. It's called medication overuse headache, or MOH. Basically, treating the pain too often can literally create more frequent pain, which ultimately requires medical detoxification to fix. Definitely something to watch out for.
Because of that risk, let's shift our focus to Section 5, preventative and chronic care.
This is the long-term management strategy for individuals experiencing 4 or more migraine days per month. When you're dealing with severe, prolonged, or frequent attacks, daily oral preventives are used. We're looking at propranolol as a first-line option, topiramate, amitriptyline, and quindesartan. But the real heavy artillery in this fight? The CGRP monoclonal antibodies. These are administered via monthly or quarterly injections, and they are just incredibly effective. For a lot of patients, they achieve a massive 50% reduction in headache frequency.
But then we reach the extreme end of the spectrum. Chronic migraine is particularly disabling. By definition, this means a patient is suffering from 15 or more headache days every single month, with at least 8 of those being full-blown migraines. Let that sink in. At this stage, specialized, advanced intervention is absolutely required.
And that brings us to a highly specialized treatment you've probably heard of, but maybe not for this: Botox, specifically onabotulinum toxin A. It is FDA and NICE approved for chronic migraine. Treatment involves injecting 155 to 195 units precisely across 31 different sites on the scalp and neck, and this is repeated every 12 weeks. This is a highly targeted approach administered by comprehensive neurology teams, like the specialists at Akkineni Hospitals, to physically interrupt those pain networks. Now, what's really fascinating here is the hard data backing this up. When compared against a placebo, Botox achieves a clear, proven reduction in headache days. Patients actually see their headache days reduced by approximately 8 to 9 days per month. That is giving them literally weeks of their life back over the course of a year. It's a safe, well-tolerated, and highly effective weapon in the chronic care arsenal. Migraine is a profound neurological condition, but as we've seen today, there is a clear roadmap to take control back from it. Proper diagnosis, trigger management, and utilizing the exact right acute or preventative therapies can change absolutely everything. So I'll leave you with this final, provocative question. Have you started tracking your triggers to build your personal prevention roadmap? Don't wait. Start that diary today, seek proper medical management, and take that first step toward getting your life back. Thank you so much for joining me on this explainer, and keep learning.